in the antenatal period, we have very high coverage of women seeking antenatal care 4 or more times. In urban areas, there's virtually no gap. The women who seek antenatal care frequently also go to the hospital when they're in labor. That's on the left side. On the right side, you see in the rural areas, we do have relatively high coverage for antenatal care, but when labor starts, we have a fall off of about 24%. And why is that? If you look at the map of Ghana, you'll see on this is a relatively complex slide, so let me take a few minutes to explain it. You'll see on the top row is the access to, top row, far right column, is the access to health facilities that provide comprehensive care if you're in labor or you have a sick newborn, complicated labor. That's the comprehensive emergency and obstetric care. Last column. On the top is if you have a vehicle. If you're traveling by motorized transport, you can get to a CMONC, a health facility that has a doctor that can do C-section or blood transfusion relatively easily. But if you're on foot or bicycle, that's the bottom row, most of the country doesn't have access to health care. So thinking about where to start, clearly the need was greatest in the northern part of the country, and the maternal and infant mortality indicators also were worse in that part of the country. So this is what we do as Maza, and we, at the inception of Maza, we wanted to rely heavily on a mobile technology platform where we would integrate the subscribers' information, GIS data, GPS, mobile money payments, etc. This was the initial vision. So our initial operational model looked like this, and the reason I showed this to you is actually I'm very embarrassed about this because I'm sitting thinking about how to get Maza started. I put the dispatch center in the middle. That's Maza's key, that was what we thought was our key value add. And then all our key stakeholders were around the model right here. As we got to talking to experts in the field, we did some formative research, got started with the work. We actually changed our operational model, both conceptually but also visually. We changed it to a model that had the pregnant woman at the center. Maza was a piece of the puzzle, but we were actually just a piece of the puzzle. The emphasis was really on the network of drivers who could be accessed when labor started or there was a sick newborn in the house. Then we launched in December. These are our key stakeholders, the drivers on the left, the pregnant women on the right. And we launched with the necessary fanfare. We had balloons and all that. These are our vehicles. They're tricycles with motorcycle engines, and they do relatively well on the rural roads. So we've been operating now for about 8 months. And I wanted to share a little bit of our data with you. This graph here shows the number of emergency transportation rides we've had in the first 8 months of Maza. As you can see, there's quite a bit of fluctuation month by month. In total, we've had about 70 rides so far, 76 passengers or so. And then I'll show you what the pregnant women have been deciding, or the families have been deciding in terms of where to go for labor and delivery. About 47% of people are going to health facilities for delivery. About 49 or so are delivering at home. And then there's a small category of people who are delivering on the way. If you add the people delivering on the way and the people delivering in the hospital, that's actually more than 50%, which is quite an achievement because just a year ago in this district, the access to skilled delivery was only 36%. So we're quite pleased with that behavior change. In terms of outcomes, I just quickly say that out of these, this pie chart, we're looking at about 400 cases. So Maza currently has about 500 subscribers, 530 subscribers or so. 80% of them have already delivered. And so these are the data for that 400 or so. And of those 400, there have been 2 maternal deaths, 2 stillbirths, and 9 neonatal deaths. And we're still monitoring the data. So let me quickly go into what we've learned and how we're changing things. Right. So what's fascinating is that the women seem to be going to healthcare facilities where they're going to labor, but they're not necessarily going with Maza's vehicle, which is interesting. They're going with their husband's motorbike or a neighbor's motorbike. And when we ask them how come they didn't call us, they tell us, well, you know, you told us to go early when labor starts, and when labor's early, we can actually sit. It's only if we delay at home and labor is too advanced, we actually need to lie down and use your motorbikes. So it appears that some of our messaging is getting through, but it's not having the impact we intended. The other thing is that we were initially hoping for mobile money savings from the women with the mobile money payment at the time of the service delivery. They've had a hard time saving or using mobile phones, period. They barely use mobile money, and they are not able, or we're not able to get them to save with cash. So it's unclear to us how much of this cost is a barrier, or it's more the convenience of having their husband's motorbike so close. The other thing that's interesting is that 60% of our passengers so far have not been pregnant, have not been infants either. So there's a lot of things that we're learning, that some of it is good, some of it is good, interesting, some of it is good, puzzling. On the iteration, so one of the things that we're thinking about, we're in the districts almost every week. We spend a lot of time doing home visits. Initially, we were issuing phones to the women because we're very interested in the mobile money as a technology platform. One of the things that we're learning, though, is that the husbands have a phone, so there's phone access in the house. Mobile money doesn't have much traction. So one of the things we're considering in the next few months is actually taking away the charge at the time of service so that we make the transportation free. And instead, for us, we emphasize our financial sustainability through the drivers, because what we do as Maza is that we procure the vehicles, we lease them to the drivers for 2 years, the drivers pay a small fee to us every week, and at the end of 2 years, they own the vehicles. And we give them, the drivers, a discounted rate, and in exchange for the discounted rate, they give us 2 days of their week they're on call for health. So one of the things that we had assumed initially is that we would scale up, and even though the cost to the passenger would be very small, at scale we would be financially sustainable because we'd have such large volumes of passengers. Right now, based on the initial 8 months, we're actually thinking the opposite, that perhaps we should emphasize rather our contracts with the drivers is where we're going to end up getting more of our financial sustainability. And for now, while demand is still low, provide the service to the families for free. And then one of the things we're also thinking about is if 60% of our passengers so far are not in our target market of pregnant women and infants, who are they? You know, as we know, most people in a community are not going to be pregnant. Who are these people? Why do they call us? Should we be targeting them? Should we be doing something different or not? And then I'll get to my last slide. So we've been iterating our model. This is what our current model looks like. And one of the things I'd like to end on is that Maza started with a big emphasis on the vehicles, but also the technology, the dispatch center and the app that we wanted to build. We were cautioned against building an app too early, and I'm very glad we didn't build that, because as we've learned more about our users and their passengers or subscribers and their uses of technology, we are still trying to figure out our strategy that best meets their need. We're relying very heavily on this model. I don't know how many people have heard of good to great, the model around disciplined people, disciplined thinking, and then disciplined action. And if you can get that right on a regular basis, you can actually get to use technology in ways that can accelerate your work. And we are not there yet. So actually, when Chikwe invited me to present, I said, Chikwe, are you sure that Maza is a good fit for this conference? Because we are using some technology, but it's fairly basic. And he said, well, that's exactly what we want to hear. So I hope I've met the expectations of the conference. I'm happy to talk to you further during the panel.